Sweden, Professor of Clinical Nutrition and Metabolism, Head of Clinical Nutrition Research Unit at Uppsala University, and also mentioned was a past president of this organization, active in many diabetes nutrition guidelines, and will be speaking on PUFAs and liver fat reduction. Ulf?
Thank you very much for that nice introduction. And first, like to thank the organizers, of course. Very nice venue, and it's good to be back in Canada. It was actually 10 years since I was here, last meeting in Toronto. So thanks for inviting me. And it's a pleasure now. We talked a lot about carbohydrates, so it's a pleasure to talk about fats and specifically effects on liver fat. And I will talk about plant-based PUFAs mainly, focused in these 15 minutes. And I have no conflicts of interest, and I can clearly state that all the studies that we have done, I will show you, we have not received any funding or grants from any oil manufacturer or food companies doing this. We bought all the oils ourselves from grants, so we try to be independent. There's a lot of debate about this plant oils and seed oils, as you know. There have been a lot of research on PUFAs, both from vegetable oils and a lot of research on N3 PUFAs from fish, which I will not talk about. We hear Ursula about that. Focus on the N6 PUFA, which is the major group of dietary PUFAs. And as you probably know, there is clear effects on liver, on blood lipids, LDL, cholesterol lowering effects, and so on. But I will focus here on the liver fat. And mainly looking at randomized controlled studies where there are not that many studies. The studies we have with PUFAs on liver fat are mainly comparing high PUFA content with a diet with a high saturated fat content. So that is the main comparison. And of course, we want to try to keep the other macronutrients, including total fat intake, but also carbs, fiber, protein, and sugars constant when comparing these fatty acids to assess the effect on liver fat and other related metabolic outcomes. Very briefly, you're all aware of the fatty liver is quite common, especially in type 2 diabetes. It's around 75% of people with diabetes have fatty liver. It's now called metabolic dysfunction associated steatotic liver disease, previously known as NAFLD. And with regard to dietary effects overall on liver fat content, there's the data suggests that it's mainly the main drivers are saturated fat intake and high sugar intake, and that is particularly clear during energy excess. But I will focus on the dietary fat quality and PUFA, in particular the plant-based PUFA from oils. And we had this hypothesis quite many years ago where we wanted to investigate the effects of N6 PUFA, which were less studied at that time with regard to liver fat, to see if we could reduce liver fat, since if you can prevent or reduce some of the liver fat, you can also, in theory, prevent the more severe liver diseases, since liver fat accumulation or fat liver is the starting point for more severe liver disease. So we try to go in to prevent steatosis and liver fat accumulation or reduce it. And it also, since liver fat per se is closely related to the metabolic disorders of type 2 diabetes and has been proposed to be possibly causal for this metabolic disorder seen in type 2 diabetes, it's a clearly interesting and potentially clinically relevant target. Liver fat is an interesting target, and PUFA is a particularly interesting dietary component. So we know from metabolic studies that different types of fatty acids are metabolized differently, and especially with regard to PUFA, it has been shown that the oxidation of PUFAs are more readily or greater than the oxidation from saturated fat, palmitic acid, which is the major saturated fatty acid, for instance. It's also shown that PUFA can downregulate lipogenic enzymes in the liver. And also we have shown, and other groups have shown, that if you give a high PUFA diet and compare it with a saturated fat diet, you will reduce ceramides, which are lipid mediators or lipid metabolites, partly coming from the saturated fat, and they are proposed to be causal or very closely involved in both in the liver fat accumulation, but also in the inflammation and the adverse effects of MASLD or fatty liver. So there are several reasons here that PUFA could have beneficial effects on reducing liver fat. Just starting with a correlation, if you look in a population-based sample where we measured MRI, liver fat MRI in a couple of hundred Swedish population, middle-aged, 50-year-old, you see that if you look in the plasma fatty acid composition, some of these fatty acids are quite good markers of dietary intake. You see that especially it's the linoleic acid, the major N6 PUFA, and to some extent the N3 PUFAs that are inversely correlated in a population-based setting with liver fat content. But that is, of course, only observational studies. So we did this HEPFAT trial, where the main aim was to see if a PUFA, a high N6 sunflower oil-based diet can reduce liver fat as compared to a saturated fat diet, mainly high in dairy fat, butter, and so on, animal fats, keeping all other macronutrients constant, and they were weight stable during 10 weeks. And interestingly, it was shown that the sunflower oil diet reduced liver fat by similar weight. There was no weight change or weight loss, and it's clearly significant compared to the butter, the saturated fat, as you can see, not reducing but increased liver fat in these people with abdominal obesity, and some of them have type 2 diabetes. And we want to go on to see if we can, since most of us are often in a hypercaloric state leading to obesity over time, small increases in energy excess leading to obesity and fatty liver. So we wanted to investigate if we can prevent this liver fat accumulation induced by saturated fats by PUFA. So basically, we want to see if you can if the matters where the excess calories come from with regard to liver fat accumulation. So we did a study in young, healthy subjects first, where we overfed these people with different types of muffins, which were identical apart from the fatty acid content. So this was a double-blinded, so the muffins were tasted the same, but we have sunflower oil in one group, and another group were randomized to muffins high in palm oil. And then the aim was to have a similar weight gain over the 7 weeks they were overfed. And this is the sign parallel, two parallel groups. And this is Frederick Rosquist, my former PhD student, worked with this. And the main results was that we achieved a similar, almost identical weight gain, a moderate weight gain after 7 weeks of overfeeding in both groups. And that was good because we want to study effects on liver fat and body composition. And if you look at to the left panel, you see clearly there that the red bars are the saturated fat, the group receiving saturated fat, equal amounts of calorie excess here. So you see there's a marked increase in liver fat accumulation when you're eating the overfed with the saturated fat diet compared to the PUFA, the plant-based muffins. And also other similar visceral fat is three times increased more in the saturated fat group. And we moved on to see if you can see this, confirm this quite dramatic effects, and very clear, was almost too clear. So thought we need to confirm this in a other study, and also in overweight obese subjects, because those were medical students and more healthy subjects. And we did this a similar protocol, same intervention, same fats, but with 8-week intervention, slightly larger. And again, we see clearly that, or we see first that we have a similar weight gain after 8 weeks in both groups, according to the plan. But again, we see, if you look to the right there, that is about 50% increase in liver fat during the overfeeding with saturated fatty acids, whereas this liver fat accumulation is completely blocked after the same amount of excess calories from PUFAs. So it's quite clear that you don't have any liver fat accumulation with PUFAs. And if we look also at sugar, there is a Finnish study from, this was dark now, I don't know. Now it's back, sorry. Yeah, 30 minutes. Yeah, okay. So this was a Finnish study from Hannelike Järvenen's group. Also looking at, also a short-term overfeeding, 3 weeks, overweight subjects. But they also, apart from having high saturated fat diet arm, they have a PUFA arm, but also a high carb, actually high sugar. It was very rich in sugar and candy and the sweet drinks and so on. And as you can see, the saturated fat group had clearly the highest liver fat accumulation, whereas PUFA had a lower, more suppressed liver fat accumulation. So saturated fat was even worse than the sugar diet there, as you can see. So this also was in line with our studies and confirmed that. So as a final, we want to do more clinical studies and implement this apparently promising effects on liver fat by PUFA, plant-based PUFA. So we have done a randomized trial now just completed. It's unpublished yet, NAFL diet trial. You might heard Mikael, my PhD student at last year, presenting this at the last meeting, where we tested an anti-lipogenic diet as we propose it. Where you basically replace the refined carbohydrates and sugars with high PUFAs. Is a lot of PUFA, 15 energy percentage, or compared to a low-fat, healthy Nordic diet, also higher in PUFA, but not as dramatic as the low-carb, high PUFA, and a usual care control group. And this was a 1-year study where the primary outcome is liver fat content. And we saw a very good dietary adherence measured as with the dietary food records, but also dietary biomarkers in plasma, and a very low drop. But rate. So that was a positive result for the study that this was also feasible protocol. And finally, very briefly, this is the preliminary results that there was a reduction in liver fat content of both the high PUFA, low carb, the so-called what we call or propose as an anti-lipogenic diet, but also after the lower fat healthy Nordic diet. And this is interesting to note that despite the low carb high PUFA diet had a lower body weight reduction, it was about half of that of healthy Nordic diet. It has a similar liver fat reduction. Yeah. And this might be explained by an anti-lipogenic diet per se after the low carb PUFA diet, which is also supported by lipogenic plasma biomarkers, which was more reduced in the low carb high PUFA diet, supporting that you have another mechanistic effect by the high PUFA low carb than the healthy Nordic diet. Both were effective. And to conclude, so replacing saturated fat with PUFA from plant oils seem to prevent lipid deposition during energy excess, but also it can reduce liver fat in people with muscle D or type 2 diabetes both in weight stable subjects. But we also recommend that both N6 and N3 should be increased, for instance, from rapeseed oil, which is a plant-based source of both these fatty acid groups. And this recent Pelham data suggests that diets high in N6 PUFA together with other healthy dietary pattern can be a good way to treat muscle D and type 2 diabetes, because I didn't show that, but you had improvement in basically all metabolic risk factors in the type 2 diabetes group. And inflammation was not increased, which is important to note. We measured a lot of inflammation and safety markers, so there was no signs of adverse effects of the high PUFA diets after 1 year in type 2 diabetes. Thank you for this.
Thank you all. I'll ask you to come back.
Thank you. The next speaker is Dr. Ursula Schwab from Finland. She is professor of nutrition therapy at the University of Eastern Finland with active research program in nutrigenetic and metabolomics. Her talk is entitled Fish versus Fish Oil for Cardiovascular Risk Reduction in Diabetes. What is the evidence?
So good afternoon, everyone. And first, I wish to thank the organizers for inviting me to give this talk in this beautiful city. I have no financial conflicts of interest and some expertise tasks related to the topic. So let's start with the significance of fish and long-chain N3 PUFA in the diet. So in the recently updated Nordic nutrition recommendations, it's stated that fish is an excellent source of high quality protein, vitamin D, iodine, vitamin B12, selenium, and unsaturated fatty acids that are non-essential fatty acids. And part of the beneficial effects of fish consumption might be mediated by that it substitutes other protein sources in the diet, for example, red meat. Fish consumption has positive effects on overall cardiovascular health and all-cause mortality, and it protects from cognitive decline. And it also has anti-inflammatory and lipid-lowering effects. And what comes to the long-chain N3 PUFA, they decrease circulating triglyceride concentrations and are associated with lower risk of cardiovascular diseases and type 2 diabetes. We have two essential fatty acids, so linoleic acid, which is N6 fatty acid, and alpha-linoleic acid, which is N3 fatty acid, and they compete of the same enzymes, so desaturases and elongases, to get more unsaturated, more longer chain fatty acids. And the genetics affects the activity of fatty acid desaturases, and on this upper right corner, you see the FATS1 genotype frequencies in European population. So about half have TT genotype, and about 10% have the CC genotype. And it has been shown in many studies, for example, in one of our studies, that the delta-5 desaturase activity is higher in the TT, those with the TT genotype compared to the CC genotype. We look at it in plasma phospholipids. And Amur and co-workers have reported the fatty acid desaturase haplotypes in human populations over the world, and there are very distinct differences. So in America, the haplotype A is the dominant one, whereas in Europe, Africa, and in some parts of Asia, the haplotype D is associated, is the dominant one, and it's associated with increased fatty acid desaturase activity, so the formation of a longer chain polyunsaturated fatty acids. And it was very nicely shown by the same group with the both in omega-6 and omega-3 fatty acids, that the longer chain fatty acids, the proportion is lower with the haplotype A compared to the haplotype D. We did a few years ago a FATS Diet 2 study where we recruited 130 healthy men from the metabolic syndrome in men study, led by Professor Markku Laakso. And this was an 8-week study. We recruited participants with the CC genotype or TT genotype and randomly assigned them either to a high linoleic acid intervention with sunflower oil or a high alpha-linoleic acid intervention with camelina sativa oil. And here in the first and third panel, you see that the compliance was very good. So the proportion of linoleic acid in the sunflower oil group and the alpha-linoleic acid proportion or concentration, actually, these are concentrations. The concentration of alpha-linoleic acid in the camelina sativa oil group, they increased. So the participants were very compliant. And then what comes to the panels 2 and 4, you see the arachidonic acid, that there was no change in the genotype TT, and there was a decrease in the concentration in the CC genotype. And there was a significant genotype diet interaction. And regarding EPA, the concentration increased in the TT genotype, whereas it did not change in the CC genotype, again with the significant difference between the genotype groups. And in the AlphaFish study, we recruited 96 participants who had impaired fasting glucose. They were obese or overweight. And we had 4 groups in a 12-week intervention, so fatty fish group, lean fish group, or alpha-linoleic acid group with camelina sativa oil, and a control group. They were allowed to consume maximum 1 fish meal per week, and no rapeseed or camelina sativa oil were allowed. And in the left-hand panel, you see the fatty acid composition of serum phospholipids. So the proportion of alpha-linoleic acid increased in the camelina sativa oil group, and the proportion of EPA increased in the fatty fish group and in the camelina sativa oil group, and the DHA, its proportion increased only in the fatty fish group. And what we found regarding serum lipid profile, total and LDL cholesterol concentrations, no triglycerides change during the intervention in the fatty fish group or the lean fish groups. But the total and LDL cholesterol concentrations decreased in the alpha-linolenic acid groups, and there was also a small but a significant difference in the control group in the LDL cholesterol concentration. What comes to the HDL cholesterol concentration, that increased in the fatty fish group, and LDL to HDL cholesterol concentration and ApoB to ApoA1 ratio, they decreased in the fatty fish group, alpha-linolenic acid group, and in the control group. So there were no changes in the lean fish group at all. Here is a study by Frank Hu and co-workers, or a report of Hu and co-workers from the nurses' health study cohort, including women with diabetes. So they looked at fish and long-chain N3 fatty acid intake and risk of coronary heart disease in these people, and they found a significant decreasing trend in coronary heart disease incidence and total mortality along with the increased intake of fish. And the same result was found with the increased intake of N3 fatty acids. In the ASCENT study, there were 15,480 participants with any type of diabetes, but no atherosclerotic vascular disease, and they received either EPA plus DHA or corn oil as placebo. And the mean follow-up time was 7.4 years, and there was no significant difference between the groups regarding the first serious vascular event. By Xiao and co-workers, there's this systematic review and meta-analysis of N3 fatty acids in type 2 diabetes. They included 46 RCTs, and they found that N3 fatty acids decrease total triglyceride concentration, total cholesterol concentration, HbA1c, and the CRP concentration, whereas there's no change in LDL cholesterol concentration, and there was an increase in HDL cholesterol concentration. And here you see an example of the analysis. So there's a triglyceride concentration, and you see a very clear decrease in the triglyceride concentration. In the HEART trial, the effect of EPA and DHA supplementations on coronary artery calcium progression was studied in participants with diabetes and coronary artery disease, and they calculated this coronary artery calcium score. These participants were randomized either to an EPA plus DHA group or a group that received nothing. So this was not a control trial, but it was a randomized trial. And this trial lasted for 30 months, and there were 242 participants with stable coronary artery disease, and 176 participants didn't have diabetes, and 66 had diabetes. And in those who didn't have diabetes, there was no significant difference in this coronary artery calcium score within the groups, whereas there was a significant increase in the coronary artery calcium score in those participants who had diabetes. And this analysis was performed by Brown and co-workers, so systematic review and meta-analysis of 83 randomized control trials with 121,000 participants, and the mean dose of long-chain omega free fatty acids was 2 grams per day, and the mean trial duration was 33 months. And they concluded that increasing long-chain omega-3 had little or no effect on likelihood of diagnosis of diabetes or on glucose metabolism. And there was a suggestion that a high-dose supplementation, so for more than 4.4 grams per day with long-chain omega-3 may worsen glucose metabolism. And then Zhang and co-workers look at the effects of EPA and DHA supplementations on metabolic syndrome. And this systematic review and meta-analysis included 33 randomized control trials. And they found that triglyceride concentration was decreased by both of those. But regarding total cholesterol and LDL cholesterol concentration, only EPA resulted in decreased concentrations, whereas DHA resulted in increased concentrations. HDL cholesterol concentration was increased by DHA only, and serum insulin concentration was increased by DHA. And they presented some mechanisms for this, and DHA reduced ApoC3 expression and activated lipoprotein lipase, leading to enhanced hydrolysis of VLDL, which was converted to LDL to a creator extent. And DHA increased inhibition of CETP activity and increased the concentration of HDL. So to summarize, the inclusion of fish in the diet is beneficial. American Heart Association recommends 2 servings of fish, particularly fatty fish per week. Nordic nutrition recommendations, there's a recommendation of consuming 2 to 3 servings per week, of which about 200 grams per week of fatty fish. And in our own guidelines, fish is included as a good source of protein and unsaturated fat. And fish oil supplements may have adverse effects. So routine use of non-prescription fish oil is not recommended. And in the recommendations by European Atherosclerosis Society and European Society of Cardiology, there's icosapent ethyl may be prescribed for individuals with mild to moderate hypertriglyceridemia or at high cardiovascular risk. And this recommendation is currently under update, and it should be out by the end of August. So we'll see what they state in the update. Thank you.
Thank you, Ursula. Okay, now Dr. Maha Tahiri, CEO and founder of Nutrition Sustainability Strategies and adjunct professor at Tufts, and will be speaking on nuts and cardiometabolic health.
Thank you.
I'll give you 2 minutes.
Okay, great. Good afternoon. So I will be talking about a roundtable that we performed last year on the cardiometabolic health benefits of almonds. So this time it's going to be about a food, and that contains a lot of the PUFAs and MUFAs and fibers and a lot of the things we've talked about today. Before I go to this work has been sponsored by the Almond Board of California. And actually, before I go to my conflicts of interest, I have a disclaimer to do. My name is Maha. It has nothing to do with the other Maha. So I am not responsible for that. I've had this name for 53 years, so I have a little bit of precedent on the name. Here are my conflicts of interest. I am a consultant and have worked for the industry for many years. So I leave it to you for a few seconds to look at it. I work a lot with startups. I work a lot with investors who are working on improving the food system, impact investors. And I also work with large companies in their health and wellness strategies. So the roundtable actually came after a very, very talented woman joined the Almond Board. Her name is Helena Hamler. She's one of Frank Hu's students. And she really looked at the large amount of data that was actually published on almonds. It's probably one of the most, the Almond Board says it's the most studied food. I I believe that. I believe that they're probably one of the, they have 200 clinical studies that were done on almonds over the last 30 years. A body of evidence that is very heterogeneous. And so it was a time for the almond board to stop and think and really analyze the data to see how they move forward with their research, to inform new research strategies, to explore if there is a consensus that can be drawn and what can be said, what can be not said, what are the gaps in research, etc., to identify opportunities for positioning almonds within emerging nutrition trends, harnessing new technologies and precision nutrition, etc., and potentially partnerships in nutrition research. The topic that we addressed at the round table, and you will see who participate in that, were dietary guidelines, food patterns, nutrient density, the effect of almonds on cardiovascular disease, and specifically on LDL, on blood pressure, on diabetes, with a focus on Asian population, and I will explain why, on weight management, microbiome and precision nutrition, and strategies for research needs and opportunities. We had a very fantastic group of people. The multidisciplinarity of the group was really one of the top objectives that we had. So we had people who worked on the guidelines, we had people who were clinicians, we were people who were food behaviorists, we had people who were experts in cardiovascular, we had microbiome experts, we have regulatory experts, we have the famous John, who's part of it. And I think that disciplinarity did really a good service into the quality of the debates and the quality of the constructive discourse that we have in the conversations. So here are the main findings of the roundtable. First of all, we found that there was really clearly a mismatch between almond consumption and what is studied in the research. The studies are done with 28 grams to 48 grams or 50 grams or sometimes 84 grams, whereas actually the population really does not eat that much of almonds. So we really thought that there was a need to explore ways of alleviating sensory-specific satiety. And I will talk to you a little bit about the next steps and what the Almond Board is planning on doing research on how to actually leverage the diversity and the versatility of almonds to increase the consumption. Under-leveraged nutrient density would have shown to show the benefits of almonds. So they've really focused on clinical trials showing outcomes, but really have not worked a lot on nutrient density. And like a lot of the topics that I worked on in my 30 years of health and wellness, this is a group of food that actually did a lot of clinical trials, but very little epidemiology. So my plea here to Frank Ho and to the Almond Board is please include almonds in the questionnaires in the Harvard cohorts, because that would help a lot advance the knowledge. Cardiovascular disease, we found that almonds can reduce LDL cholesterol by about 5 milligrams per deciliter, that they are rich in saturated fats for fiber, which supports heart health. And there is a qualified health claim by FDA that has been approved many years ago. For diabetes, things were a little bit more complicated. Meta-analysis on fasting blood glucose and oh my gosh, I will never be able to say that one. HbA1c. English is not my native language, so show mixed results for Caucasians specifically. Significant HbA1c reduction in type 2 diabetes patients, but more research is needed. And we saw a subpopulation effect on South Asian, reducing fasting blood glucose and HbA1c levels. However, what we saw was that when the studies were done with South Asian population, we saw effects, but there was not a study that actually compared the effects of Caucasian and South Asian. So that was a gap of research that was actually identified for the almond board to perform a study in, or any of you who wanted to do that. On weight management, we have a lot of discussions. Studies showed no weight gain from almond consumption. Up to 50 grams addition of almonds to the diet did not actually increase weight, but either maintain or slightly decrease weight. And I remember France Belil in the whole meeting saying, this is a mystery that we need to solve because we're adding 50 grams of almonds, and consistently in all the clinical trials and the meta-analysis, we're not seeing. And actually the same thing has been observed for pistachios. So right now we're doing, to really understand the mechanism and what happened, we're doing a behavioral study where in Écully in Lyon to really look at when we add 50 grams of almonds to the diet of people, what do they do? And we're observing their behavior. Do they compensate? Do they eat less carbohydrates? What happens in their behavior that could explain beyond the mechanisms that are inflammation or microbiome or other things. Blood pressure, small but significant reduction in diastolic blood pressure from almond consumption, but no consistent effect on systolic. And the effect might vary based on the duration and the dosage. The big learning for future research. The almond board did a lot of studies, but this is not a syndrome of the almond board. I think this is a syndrome of nutrition. We need to do fewer studies, but larger and better powered. And that's really a message that was clearly taken into account by the almond board. We need to understand the mechanisms behind the effects to get stronger position with key opinion leaders and authoritative bodies. Because if you don't understand why people can add 50 grams of almonds and maintain their weight or lose weight, there is a lack of credibility of that finding. We need to leverage more nutrient density in a more comprehensive way to position almond as a better food than a collection of nutrients, which they have been doing so far. And I can tell you that right now we're doing a lot of modeling with NHANES, with substitutions with unhealthy snacks, with substitutions with at different percentages, with addition of almonds and addition or substitution, and we're seeing an increase in the healthy index. Behavior studies are to improve the consumption and assert the position of almond in weight management. Focus on susceptible populations, as they are the vast majority of the population or specific population like Asian population diabetes. Use the effective dose. When we looked at all the studies that did show an effect were of 50 grams, and the duration of the studies were 12 weeks or more. And so this was a very clear direction to take. Rigorous microbiome research. We have the fantastic Jack Gilbert there who really challenged a lot of the studies that were done on the microbiome. And again, this is not only for almonds, but we tend to take pictures of what's happening in the microbiome. And the way he talked about it, it's like, it's really, we need movies. We need the movies of what's happening between these populations of microbes versus just pictures of that cannot really not give us the real story of what's happening in the microbiome. And develop diets and strategies to improve the level of consumption if there is this big mismatch between the consumption. Well, it took us 1 year to actually do a lot of work in preparation of the face-to-face meeting that happened in Modesto in July of 2024. And by November of 2024, we have the consensus paper published in Current Development in Nutrition. And here is an extract exactly with the verbatim that was used for each of the elements that I talked about. Consuming almond daily does not result in weight gain, tendency for higher almond intake to be associated with slight weight loss. Consuming almonds daily is a consistent, small, significant average reduction 5.1 milligram, 5% based on mean population level LDL cholesterol level in the US. Consuming almond daily results in a small significant average reduction, 0.7, 1.3 milligram in diastolic blood pressure, while almond as a single food produce average reduction in LDL cholesterol and diastolic blood. They are clinical small for they are clinically small for individuals. These reductions have significant public health benefits and can be meaningful for individuals when combined with LDL cholesterol and blood pressure lowering effects of other foods. And this was really one of the biggest learning, which was really convincing. The commodity boards, they work with their food in mind. And one of the learning was, okay, we really need to be now talking about foods and patterns and diets and combined foods that actually will result into the same outcome or reinforce the same outcome. And so there's a lot of openness into combining foods that and doing studies with combination of almonds with other things that actually can increase the effect. Consuming almond daily by Asian population with pre-diabetic can result in a significant reduction in fasting blood glucose. You can read the rest. Almond consumption results in a decrease. How am I doing in time? 2. Perfect. Okay. I actually did say all of that. Just want to finish with the key elements of success. I think we have a high caliber of experts group that showed a lot of openness in debating the ideas. There was a huge amount of pre-work that was done with really looking at all the studies, all the meta-analysis, all the systematic reviews, and was summarized for the experts with multiple calls with the experts prior to the physical meeting. We had clear objectives. The commitments of the Almond Board for not influencing the experts. So the Almond Board was nobody from the Almond Board was actually involved in the conversations with the experts. They were observers in the roundtable and did not give any input into the paper until it was submitted. That's the first time they saw the paper. And so that I commend them for that. They were in the room. We had the CEO of the Almond Board who was there the whole time, which was a surprise. And we did have some fun, which actually does not take anything from the seriousness of the work that was done. We visited an orchard, we visited a facility, and we had a lot of very intense conversations. So thank you for your attention. And I think I'm on.
How many almonds in 50 grams? 50 almonds. Can you just say that?
The question was, how many almonds in 50 grams? Around 50 almonds. That's a lot.
Thank you very much. The next speaker is Anthony Hanley from Canada. He's a professor and associate chair in the graduate education in the Department of Nutritional Science, University of Toronto, and scientific at Leadership Sinai Center for Diabetes, Mount Sinai, Hospital, Toronto. His talk will be role of dairy matrix in cardiometabolic risk reduction. Thank you.
Thank you very much for the kind introduction. Thanks to the organizers for inviting me and to the sponsors. And a special thank you to Sabrina for being the Chief Technology Officer today and keeping everything rolling smoothly despite an occasionally misbehaving technology platform. So thank you very much. My disclosures, this is mostly related to keeping my research program going. I also do service for these agencies as a grant reviewer. So John and Laura and Cyril gave me a very ambitious assignment today to look at dairy, the dairy matrix in cardiometabolic risk reduction. My work is in diabetes, mostly prediabetes phenotypes and their progression using observational designs. So I'm going to focus mostly on diabetes and the early diabetes phenotypes, but I think these are helpful more broadly in understanding the larger picture of cardiometabolic health. We'll look at evidence from human studies. There's a lot of preclinical work in this area. I won't be covering that. The importance of the dairy matrix, and then a quick touch on some potential mechanisms. So perhaps a helpful place to start is the publication a couple of years ago of the American Heart Association's framework for cardiovascular kidney metabolic syndrome, CKM, which really brings together under a shared vision of common pathophysiological antecedents for all of these disorders. I think a lot of us recognize that already. The clinicians in the room will see how these tie together, and we all have had a sense of how these things hang together, but this was a nice encapsulation of that. And if you look at the staging that was proposed, I thought this was very interesting because in the early stages, particularly stage 1, there's the recognition of the importance of early pathophysiological phenotypes, adipose tissue dysfunction, inflammation, prediabetes, these kinds of things. And then if you go upstream of that, the recognition that lifestyle, including diet, is a very important factor in the primary prevention of this cascade. So Alan in the previous session gave a very nice synopsis of the difference between incidence and prevalence. 10 out of 10, I support that entirely. And there is data from well-resourced places in the world, including Australia, Canada, other places that are well-resourced, that suggest that incidence of diabetes is either leveling off or declining. That is not everywhere, and that is not incidence of 0, which means we still have new disease entering the population. We've gotten better at keeping people alive with diabetes, and what that means is prevalence continues to increase. This is an IDF Diabetes Atlas, current burden, current prevalence, and projections out to 2045. And the situation is getting worse, especially in places that are not equipped technologically or financially to deal with the tsunami of diabetes management and complications. And so we really need to figure out and give some attention to primary prevention. This will be familiar to many of you. We recognize that diabetes is a disorder of insulin resistance in multiple tissues, muscle, liver, adipose tissue. The pancreatic beta cells mount a heroic response, but because of underlying reductions in beta cell function or mass are acquired through environmental factors, hyperglycemia eventually arises when the beta cells are not able to manage insulin resistance. This process takes a while, and so if you look at the left, the light blue area, it can take years or decades before the diagnosis of type 2 diabetes, where we're seeing progressive declines in insulin sensitivity and beta cell function. And my research program all lives in that blue area. We're trying to understand, using observational designs, what are the factors that drive or slow that slow progression of insulin resistance, beta cell function, adipose tissue dysfunction, et cetera. Here's another way to look at it, really highlighting these prodromal or early phenotypes, adipose tissue dysfunction, inflammation. We heard about MASLD earlier. You could add gut inflammation, subclinical inflammation in general, leading to insulin resistance, beta cell function, et cetera. There can be some debate about where insulin resistance sort of occurs. Some would suggest that's earlier, but this is a helpful framework. And what's important is that there are modifiable risk factors that act all along this pathway, including diet. Now, I don't have to spend any time on this slide because we've had some really fantastic presentations all day today on many of these elements that we know very solidly are related to either decreased risk of diabetes or increased risk. Where we're going in a lot of nutritional epidemiology is diet patterns. So DASH, Mediterranean, et cetera. And so I'll just show one slide, a few examples of these diet patterns, DASH, Mediterranean, and the prudent diet, which we get from a posteriori factor analysis assessments. So they all share some common factors: fruits and vegetables, whole grains, eliminating sugar-sweetened beverages, et cetera. But dairy products in different forms are key parts of all of these, either low-fat dairy or fermented dairy. So what do we know about the role of dairy products in the prevention of type 2 diabetes? And so I'm going to show you some meta-analysis results. I've learned a lot from John over the years that this is a really nice way to encapsulate the collectivity of the results on a given topic. And helpfully, Alvarez Bueno and colleagues in 2019 published a nice paper that presented an overview of meta-analyses that had been published to date. So what we're looking at in these next few slides are a collection of summary relative risks. These are not the individual cohort studies. These are summary relative risks from other meta-analyses. What we can see from total dairy is that there's a fairly consistent inverse association with the incidence of diabetes. There's one exception there, but most of the evidence is suggesting either neutrality or inverse associations with diabetes. Now, people don't think about dairy in terms of consuming total dairy. They're making decisions about whether they're consuming yogurt, cheese, or milk, or maybe they make a conscious choice regarding low or high-fat dairy. So let's take a look at that. Yogurt data are very, very consistent, and this has come up several times today already. Yogurt is very consistently inversely associated with incident type 2 diabetes. Andrea is going to talk after me, and so I'm not going to take a deep dive into yogurt because we have a clear signal there. Now, for milk and cheese, it's a little bit more mixed. Most of those point estimates are below 1, but you can see the findings are a little bit more mixed in terms of significance. Even more complex, perhaps, is the low or high fat presentation of these meta-analyses. And the nutritional epidemiologists in the room will recognize the enormous complexity of what happens to get those, to form those buckets in terms of what is listed on the FFQ, high versus low fat, how people are remembering and reporting those foods, how these are consumed in different parts of the world, and how that all gets into these summaries from these meta-analyses. We can see there's a consistent inverse association with low-fat dairy. The data for high-fat dairy are a little bit more mixed, indicating neutrality, at least in this series of meta-analyses. I will point you to a very good perspectives paper from March of 2025 in the AJCN on this debate between regarding high and low-fat dairy. Benoit Lamarche, who's with us here this week, is the first author on that paper. More recent meta from Feng and colleagues looking at diabetes as well as hypertension and obesity. Generally similar story from what I've told you, with some interesting findings regarding hypertension and obesity, and I won't take a dive into that. That was observational work. What do the trials tell us? So here is a meta-analysis of 38 trials, over 3,000 participants. This is from our colleagues at Laval University in Quebec City. And they found, interestingly, that people randomized to higher dairy intake actually had a slight increase in fasting glucose in this meta-analysis, and in contrast, a slight reduction in A1C with no impact on measures of insulin resistance. Very, very good paper from a German group, a network meta-analysis looking at a range of cardiometabolic outcomes in a meta-analysis of trials on this topic, 19 trials, 1,400 participants in studies of 12 weeks or longer. No detrimental effects of higher dairy on anthropometry, blood pressure, or lipids. Some improvements in waist and lipids with high yogurt and in BP with full-fat dairy. But again, we see these slight increases in in glucose, and in this case, A1C in the groups randomized to higher dairy. You'll see from the network plots that these results, especially for the low and high fat dairy, the association for total high dairy versus control is null, but the low and high fat results, there's very, very few studies, 1 to 2 in each case. And again, no associations when they broke it down by individual dairy products. An interesting meta-analysis on insulin resistance. I'm interested in that phenotype, and so I read this paper indicating that high dairy was related to lower HAMA-IR, a conventional measure of insulin resistance. But this was an interesting meta in that of the 14 studies included, about half, only half were dairy, high dairy versus low dairy intervention in isolation. The other 7 were mixed interventions that happened to include dairy. So difficult to disentangle dairy per se, although maybe you could argue that's maybe the point, dairy in the context of a healthy diet. So take-home points to this point of the talk. Prospective studies are showing inverse or neutral associations of total dairy and pretty consistent inverse associations of yogurt and low-fat dairy. The trials have been more mixed. We really need more work in this area. bigger, longer-term, better quality trials to improve the evidence base regarding this question. I'm getting near the end. What are the potential mechanisms? So dairy is a marvelous vehicle, a delivery system of a wide range of healthy macro and micronutrients, protein, vitamins, minerals, carbohydrates. The matrix itself is very important in terms of modulating or catalyzing some of these beneficial components. Probiotic content, fermentation, the entire processing of the matrix may have a range of benefits. Mosafarian in 2018 wrote a very nice review of this, and you can see in this figure the different aspects of dairy, how they may influence different cardiometabolic pathways. My group is interested in dairy fat, particularly some of the unique fatty acids found in dairy. Dairy is very complex in terms of its fat content, 400 different fatty acids. The first thing to touch on is the milk fat globule membrane, the tri-layer membrane surrounding the triacylglycerols, proteins and milk polar lipids, and there may be some mechanisms here in terms of reduced intestinal cholesterol absorption. Because I do epidemiology, I'm very concerned about the way I capture dietary intake. Food frequency questionnaires are excellent. I love them. I'll defend them to the end of the day, but I also recognize their limitations and why biomarkers may help us. And so this issue is a little bit controversial, but most of the literature suggests that these fatty acids listed here, the odd chain saturates and the ruminant trans, are exogenous, and so we don't make them, and therefore their detection in human serum or plasma can serve as biomarkers of intake. We looked at this in the PROMISE cohort, which is a small cohort that we have here in Ontario. 2 students worked on this, Ingrid Santorin and Anna Yahia. We've been following a prediabetes cohort for about 20 years now, and what we found was that pentadecanoic acid 15O was longitudinally associated with better beta cell function, transpamidylaic with better insulin sensitivity, and all of these fatty acids with better glucose values longitudinally. Anna is interested in branch chain fatty acids. How is my time? 2 minutes. I think I'm on track. So branch chain fatty acids are predominantly saturated fats that contain a methyl branch near the terminal group. And so you can make these from branch chain amino acids yourself, or you can obtain them from the diet. And Ran Ressler from the USDA did some nice work on dietary sources. So we took a look at this. I should mention these fatty acids were measured in the lab of Richard Bazinet, a real fabulous collaborator to many of us in the room. And the story was a little bit mixed for these branch chain fatty acids. ISO and anti-ISO 15O and ISO 16O positively or beneficially related to longitudinal changes in insulin sensitivity, but some of the other isoforms, the other individual fatty acids, ISO 14 and ISO 18, I believe, went in the opposite direction. So this is complex. We're working on this. These are hard to detect. You need to set up the gear and buy the standards the right way and tweak the instruments. And so we're continuing to work on this, adding more time points and improving the measurement in the lab. So just to conclude, cohort studies, consistent signal of neutral or inverse associations, dairy subtypes, real consistent signal with yogurt in particular and low-fat dairy. Trials, a little bit more mixed, but we need more of them. I'm not a trialist, but I'm a fan. We need more of them and to improve that evidence base. Lots of really cool mechanisms around fermentation, around a range of things, including the fat profile. Thank you to students, especially colleagues, funders. Thank you very much.
Thank you, Anthony. All right, Amanda Bleckman will be speaking. She's an RD and Director of Nutrition and Scientific Affairs at Dannon North America. Will be speaking on yogurt and type 2 diabetes risk reduction.
Thank you.
Great.
How you guys doing? Last one of the day.
10 minutes.
Yes, 10 minutes. I know I'm not going to waste a precious moment, but just everyone take a deep breath, give ourselves some energy. We can do this together. All right. So thank you so much. I'm really honored for this opportunity to speak to all of you today. As he mentioned, I am an employee of Danone North America. I would argue, though, that our interests are not in conflict. We actually are quite aligned. A quick overview of how I'm going to present and what I'm going to talk about today. I split it into three parts. First of all, the qualified health claim. Maha actually, set it up a little bit there. What is this qualified health claim for yogurt? There's many for nuts, but what is it? How did we get here? How did this claim happen? Teaser, a lot of you in the room were actually very instrumental in helping make this qualified health claim possible. And then why does it matter, right? How do we take this tremendous public interest and move it towards action to actually benefit public health? And finally, I'm going to share some real-world examples of how we at Danone have really leaned in on this messaging to help move towards actionable, proactive activities that people can really take part in to effect positive change, and how collaboration between health science and industry can be really critical for this. Okay, so first of all, the qualified health claim. Just a little bit of history. Back in 2014, I was just a baby at Danone North America, and we started to see some really promising emerging science showing what we've all talked about today, a consistent link. I'm not sure what that is. A consistent link between yogurt consumption and a decreased risk of type 2 diabetes, in the context also of continually rising rates of diabetes. We also saw that qualified health claims can have a significant impact on how people perceive foods and how it impacts their consumption behavior. So Maha did actually reference this a bit, but nuts is one of my favorite examples. I think someone earlier said something about the fat-free 90s. I don't know about you guys, but I certainly grew up in a household of like fat-free pretzels, fat-free cookies. Everything was non-fat. And that was the way towards health. But a couple years later, as the science continues to evolve, okay, maybe it's not total fat, maybe it's the type of fat, right? And as we continue to move forward, fast forward to 2003, when we see the first qualified health claim for nuts announced. And 2 years after that, nuts were included in the dietary guidelines as a food to encourage. So really over the span of 10, 15 years, there was such a turnaround, and all of that was because of science. So that was really inspiring for us. So then from 2015 to 2018, we took a long time to really dig deep into the full body of evidence, looking into all of the available literature, and compiling a petition that was submitted to the FDA with a request to consider a qualified health claim that yogurt may reduce the risk of type 2 diabetes. It then took the FDA several years to review all of this information. There were a couple of, minor things like a global pandemic and an unprecedented infant formula shortage that, might have gotten a little bit in the way. So it took some time to really go through the evidence. But ultimately, in the beginning of 2024, they did announce a qualified health claim for yogurt and type 2 diabetes. And they evaluated all of the available evidence. They did their own literature search and were able to draw conclusions from 28 different observational cohort studies, over 800,000 individuals in 10 different countries. And I just want to take a moment and acknowledge that there are several people in this room who published some of this work that really made this possible. So taking a moment to say thank you, but also we should be so proud of what this did together. So just a bit more about what is this claim. In its entirety, it states, eating yogurt regularly, at least 2 cups or 3 servings per week, may reduce the risk of type 2 diabetes according to limited scientific evidence. And there are a few things to consider when thinking about how to apply this claim. Number 1, it has to be for a dairy yogurt, because the food frequency questionnaires were looking at dairy yogurt. So it's not applicable to some of those plant-based alternatives that are starting to hit the market. There are also some regulations that are relevant for all health claims. So not relevant specifically just to this one, but for all health claims, you have to make sure that a food has at least the minimum qualifying levels of beneficial nutrients and also doesn't exceed any disqualifying levels of total saturated fat, cholesterol, and sodium. You'll probably notice added sugar is not included in that list. It also was not specifically limited in this qualified health claim for yogurt, but in its letter, of enforcement discretion, the FDA did recommend careful consideration when linking the claim to products that could potentially add significant amounts of added fat to the diet, just to avoid any unintended consequences or impact on diet quality. So immediately following the announcement, there was tremendous media coverage. There was a ton of consumer and public interest in this claim, and we saw this in the way that it was covered in the media. There were over 4.5 billion media impressions. To put that into context, because it may not mean anything, this is what some companies pay for Super Bowl ad outcomes. And this was entirely organic coverage because there was so much appetite for it in the public to learn more about this incredible new health-related information. What's also, I think, really impressive is yogurt searches increased by over 50%. So people going to their browser, going to their search engine and typing in yogurt or related search terms spiked, but also sustained for 45 days. And so in this day and age when every news cycle is a couple of days, like that's long, that's generous, a minute. The news cycles are fast. So to be able to sustain the interest is, I think, incredibly telling and really, really promising. Okay, so why does this matter? Why is this important? Why is this a key moment of opportunity for all of us here together? We know we have the evidence. So many of you talked about it. Karen talked about the protective role of yogurt. Frank showed us that yogurt stands out amongst other NOVA-4 foods as actually having a protective impact. Anthony just laid out a ton of the research. We know we have this association. We also know that diabetes continues to be a significant issue in the US. And finally, we know that people are more interested than ever in proactive approaches towards their health. No longer is it just, I'm sick, I need to do something to get better, but people are really interested in, I need to do something now, today, so that I don't get sick tomorrow. And so this is a key moment. And what do? We need to move towards action, but how we translate the information and how we amplify it to make sure we're reaching the right and the best and the biggest audiences where it's gonna land and be relevant is key. I think, who said it? I think it was Joanne said something earlier. We've known about fiber forever, right? But people didn't care until it was relevant because now GLP-1s are so popular and suddenly it's landing. It's a similar concept here. We have to make it relevant and something for me that I care about that I'm going to take and use. So now I just want to give a couple of real-world examples of how at Danone we've really been leveraging this messaging to improve the health of the public, of the people that we serve. So I'll share some information about how we've been engaging with healthcare professionals, how the digital tools that we've been creating, and some really interesting work I think we're doing by partnering with retailers to help make the healthy choice the easy choice. So first, we've seen that collaboration with healthcare professionals has really led to positive advocacy. Once this information was available and consumers were consuming this information online, we wanted to make sure there's a consistent feedback loop when they go talk to their healthcare professional. And what we saw was that as we engaged with dietitians, with doctors, they were really interested and they continued to bring that message to the public. So dietitians, we saw them writing about it in the media, sharing information on their social media platforms, and actually coming to us at Danone as a credible resource to learn more about diabetes, to learn more about the claim, and to see if they could get resources that they could then share and pass along to their patients. We also brought this message to patients in doctor's office waiting rooms. So you can see this example in the bottom. What are you, left? Okay, where are you guys looking? In the bottom left of your screen, they would get exposed to diabetes messaging in the waiting room, and the intention is that this can be a catalyst. This can really spark conversation when they go in and see their doctor and say, okay, this is something I've been concerned about. I have a family history of diabetes. I'm worried about it. I just saw something about yogurt. Is that something that's right for me? And how should I do that? Because we want to still maintain that patient-centered approach, but this information is for all. And then how we apply it is really an individual thing. Okay. So the next thing I want to share is just how we're meeting people where they are. We know that the majority of people are getting their information online these days. So we created a lot of education and a lot of tools that then we put online to meet people where they were and really help drive engagement with this information. So we created a digital platform on the Danone North America website that had education, information, recipes, other useful tools that people could learn more, especially with those yogurt search terms rising. People were looking for and craving this information. And what we saw was that it increased significantly only the traffic to the website, but it also had really strong engagement. People spent more time on the website and they clicked through different content more than they had prior. And what this means for us is that we have an opportunity to continue building this content because people want it, and to continue partnering with credible experts to bring more of that information to the people who need it. And finally, I think this is really a very exciting, way to, again, as I mentioned, make the healthy choice the easy choice. We partnered with some key retailers to see if we could bring awareness to the claim, but also quickly convert that into action. And so we worked with a couple of different retailers and put digital display ads both on the retailer website, but also off the site. So where you might be looking for meal prep ideas or searching for breakfast recipes, you're served, whatever content that you're looking for, a yogurt parfait. And next to that, you might see an ad that gives you information about the qualified health claim. From there, you click through that link and it takes you right to a really easy shoppable digital shelf. So immediately you're thinking about planning your breakfast. You want to make a breakfast bowl with yogurt. You know that yogurt might help reduce your risk of type 2 diabetes. And suddenly you're able to just click and get it into your house and get it into your fridge. And what we saw was that, of course, it drove, more traffic to our brand. But I think more importantly, it really increased new households into the category. So people who hadn't bought yogurt in the past year were suddenly buying yogurt. And people who hadn't bought from these key retail partners in a year were also purchasing there. And I think that's really important too, because for us, it's showing them that healthy foods and nutrition messaging really resonate and are things that they should be focusing on too, making sure they're focusing on the healthy options that people can be shopping at their stores. And so I'm going to leave you, I think I'm at my time, I'm going to leave you with just a quote from Helen Keller: "Alone we can do so little, together we can do so much." No disrespect, I think that alone, you guys are doing amazing. So alone, we're doing quite a lot, but together, it's just so much more. I'm really inspired, by, just being in the room with all of you. I'm a little bit starstruck, but just what we've been able to accomplish together by taking this, the science and turning it into something that's really been meaningful and powerful and very exciting for the public. And I'm just excited to see what else, can come of industry and health science community collaboration in the future.